Good afternoon, everyone. This is Leanne Griffin with FATA. I just wanted to let you know that we do expect to get started in about 5 minutes. In the meantime, I've dropped some technical information in the chat panel that you might find helpful. Thank you. Good afternoon, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Correctional Health, Addictions, and Treatment Options. This webinar is being made available through a collaboration of the Office of the State Courts Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. So you may use the Q&A panel to send questions as you think of them, and the presenter will address those questions as time permits today. Our audio is being broadcast through the internet to your computer. But if you experience poor computer audio, there are a few options to try on screen right now, and I've posted these in the chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen to receive a statement of credit. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. Also, a PDF version of the PowerPoint presentation will be emailed to participants within that same time frame. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families and the Office of State Courts Administrator. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA website. You will first need to register or sign in to your account to complete the evaluation, and any information you provide FATA as part of registering does remain confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive continuing education credits or to access your statement of credit. And please do note that the evaluation will close at midnight on Wednesday, December 19th. So again, that's tomorrow at midnight. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. And do note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a statement of credit if you do not attend the entire webinar, and we're not permitted to provide partial credit. I'd like to go ahead and introduce our presenter for today. Dr. Ruth Potee is a board-certified family and addiction medicine physician at Valley Medical Group in Greenville, Massachusetts. She serves in various capacities, such as the medical director for the Franklin County House of Corrections, the Franklin Recovery and Treatment Center, and the Pioneer Valley Regional School District, as well as the co-chair of the Opioid Task Force of Franklin County and the North, Dr. Potee, is it North Cabine region?
Quabbin.
Quabbin, thank you. I knew I was going to mess that up. And the North Quabbin Region's Healthcare Solutions Committee and chair of the Department of Medicine at Bay State Franklin Medical Center. Dr. Potee was honored as Franklin County's Doctor of the Year by the Massachusetts Medical Society in 2015. She engages communities in discussions surrounding substance abuse through her wide-ranging series of talks. Dr. Potee recently conducted a day-long training for a FATA MAT provider and was recruited for today's webinar. More of her work and background can be found on ruthpotee.com. So we're very pleased to have Dr. Potee join us today. And Dr. Potee, if you're ready, I'm going to bring up your slides, and then I'm going to transition control over to you.
Thank you, Leanne. Hi, everyone. I hope everyone can hear me because it looks like the talking sound is on my side of the world. Welcome to this webinar. I actually don't often do webinars. I'm normally in a room staring deep into everybody's eyes. So instead, I know everybody's sitting at their work or home desk staring at a screen. You all are in sunny Florida. I am in Massachusetts where it's 20 degrees and really blustery. So just look out the window and appreciate your beautiful state. So we're going to talk a very big picture conversation in the first 1/3 of this about how the brain breaks with addiction. And then we're going to spend time, obviously, talking about corrections and treatment in a correctional facility. And I am going to have, I think, plenty of time for questions. And so I will try to answer questions as we go along, unless I feel like I'm getting confused or off track, in which case I'll postpone questions and have Leanne try to put the questions together in some workable fashion. So I'm just trying to flip my screens here.
And Dr. Potee, there you go, you got it.
Yep, got it. So we're going to talk about this extraordinary organ in the body known as the human brain. On the day of life that you are born and the day that you die, most of your organs are doing the exact same thing. Your kidneys, your pancreas, your stomach, everything works the minute you're born, and it stays functioning, if you're lucky, until the day you die, without a lot of change. The brain, on the other hand, is really shifting from the minute you are born, and it changes dramatically in the first 3 years, and then 7 years, and then 24 years of life. But as we all know, listening to this, our brains are shifting and learning new things and making new connections all the time. So it really is this extraordinary organ. We know that one of the reasons that addiction is such a significant disease in our society is because it impacts the part of the brain that tells us to live or die every day. It impacts the reward circuit of the brain. This is the most ancient elemental part of the brain. 3 of the main areas are the nucleus accumbens, the ventral tegmental area, and the prefrontal cortex. But I really think of this as the eat, drink, and have sex part of the brain. It's the most ancient elemental part of the brain. Every cricket, every koala, every human has this part of the brain. And it's the part of the brain that tells you to get up every day and survive. And if we could pick up the disease of addiction and move it somewhere else in the brain, and it went to the auditory cortex, and you just lost your high frequency sound ability, that would be fine. We would get everybody some hearing aids, and maybe I wouldn't let somebody with addiction pilot an airplane, but it would be a very easy to manage disease to treat. But instead, addiction impacts the part of the brain that tells you to survive. And as everybody listening to this, because I imagine everybody who's listening to this treats and helps people with addiction, what you all know is that when somebody struggles with a substance use or behavioral use disorder, they really have a really hard time getting to the other side of it. So racing through this reward circuit of the brain is the neurotransmitter known as dopamine. And dopamine is the, holy smokes, it was awesome, do it again chemical. It gives you this sense of joy and euphoria, and it rewards you for behaviors associated with surviving a long time. Great food, finding a partner, and sending your genetic material forward. It has with it associated fine motor skills, which is one of the reasons why, as an example, quitting smoking is so hard. That The hardest cigarette to lose is that first one in the morning with the cup of coffee. There's a lot of ritual associated with that, and you're waking up in nicotine withdrawal first thing in the morning. But the other hard cigarette to lose is the one you lose while you're driving, because just the motion of touching the door handle on the car and then the steering wheel and unpacking that crinkly cellophane that wraps your box of cigarettes and tapping out a cigarette and lighting it helps feed into this dopamine circuit in the brain. And what everybody will tell you is even people in recovery, they'll miss the works, they'll miss putting on a tourniquet, they'll miss finding a vein. There are people out there in recovery who will inject normal saline because they miss so much of that finger, hand, body association. And so when people are in treatment, when people are in recovery, you need to find ways of occupying the fingers. I know great therapists out there who've taught themselves to knit or crochet so they can teach their clients how to knit or crochet. Now, obviously, in corrections, we're not having crochet needles or knitting needles around, but having activities that make use of the fingers makes a big difference for people to get to the other side of this disease. Associated with the dopamine system and the reward pathway in the brain are two specific behaviors. One is called compulsion, and the other one is perseveration. I cannot stop thinking about this, and I simply have to do this thing. Those two behaviors of compulsion and perseveration are awesome when it comes to survival. Your ancestors living in Florida or in New England 200 years ago found it very challenging to survive. It was hard to find enough calories to get through the day, to get through the week. People rarely made it over the age of 35. It was a struggle to live every day. And people who were trying to live every day, the last thing they thought of when they went to bed every night and the first thing they thought of in the morning is, how am I going to keep my family alive? How am I going to protect my children? Do I need to pack up, move further down the river to find some more salmon because things feel like they're getting scarce here? Being compulsive and being a perseverator as a survival technique are awesome behaviors. And you're grateful that your ancestors were compulsive and perseverating. And people who weren't good at that didn't make it through generations beyond them. So the problem is that everybody listening to this also can recognize that compulsion and perseveration define the disease of addiction. And for many of us who take care of the same people year after year, who see high recidivism rates, who take care of the same people either entering jail or entering treatment again and again, acknowledge that these two behaviors of compulsion and perseveration define addiction. And we don't kick them to the curb. We sort of acknowledge that this is a frequent pathway, which is that people relapse. I make an argument that at a baseline, we all have a certain amount of dopamine racing through our brain. And for the sake of this argument, I argue that there's about 100 units of dopamine on average. Now, there's no way to measure this. This is not a blood test, a serum blood test, or a urine drug screen. This is a concept for everybody to understand. Some of us are these happy-go-lucky golden retrievers on the planet that have higher dopamine than average. We're sitting at 108 most days, and people turn to us when they're feeling low because they know that we'll often make them feel better. Some of us have baseline lower dopamine levels. Maybe we're sitting at a 90 or a 95 or an 88, and that too can be normal. There's a range of what is normal in the brain for dopamine. And we know, for those of us who live with lower dopamine, what it takes for us to feel better. We exercise, we connect to other people, we go out dancing, we listen to music, we eat chocolate, we do things that make us feel better and bring us up. So if on average, all of us are sitting at about 100, and you find the perfect food that's going to keep your people alive for another week because you found the salmon, you were able to shoot a deer, you get a spike in dopamine, and your dopamine will spike to 150, and then it will go back to normal. You have sex, it's consensual, you have an orgasm, your dopamine will spike to 200, and then it will go back to normal. Because these are behaviors that your brain has seen for 200,000 years, and it is a mechanism that has allowed us to survive as a species. The problem is when we start to enter into the world of addictive drugs or addictive behaviors where we start to see dopamine spikes that are not within a range of normal, and our brain starts to get very confused. When you use a drug like cocaine, your dopamine will spike to about 350. And when you use a drug like a prescription opiate or a strong injection opiate like heroin or fentanyl, your dopamine will spike between 500 and 900. And when you use a drug like crystal meth, it might go as high as 1,300. And we have new meth that's coming in from Mexico that's even more potent. It probably goes higher than 1,300. So your brain, when exposed to this, sees these huge levels of dopamine racing at it. So let's just talk a little bit about the equation that makes dopamine in our brain. There's three things in this equation: how much dopamine is produced in the reward circuit of the brain, how many dopamine receptors are receiving information on the other side of the synaptic cleft, and then how many little reuptake transporters or little tiny vacuums are in the synaptic cleft sucking the dopamine out. So there are these three things that impact our experience of dopamine in the brain. And I'm only going to talk you through two things. I'm not going to go through gambling addiction or gaming addiction, but everything, whether it's nicotine addiction, marijuana addiction, gambling addiction, it all ends up in the dopamine circuit. I'm going to cover two fast things so we understand it. Cocaine works in one very simple way. All it does is turn off the reuptake transporters. It turns off the vacuum. So when there's nothing sucking dopamine out of the active part of the brain, it can build up to a level of 350 in the synaptic cleft. And you would think that cocaine use disorder would be very easy to treat because its mechanism of action is so simple. All we need to do is modify the reuptake transporters in a way that it doesn't respond to cocaine anymore, right? Like a little tiny vaccine would fix this problem, but we haven't figured out how to do that yet. Somebody in the audience will make a gazillion dollars if they can figure that one out. So cocaine's mechanism of action is well understood. As everybody on this call knows, there's no effective treatment for cocaine use disorder. Contingency management, when we pay people or we give rewards to people of some sort for not using cocaine, is the most effective treatment. We know CBT, DBT, other kinds of behavioral modifications may make a difference. There's no medicine out there that has good evidence behind it for treatment. We've tried a lot of stuff. It mostly doesn't work. Heroin or opiates in general impact the equation of dopamine in the brain in a different way. They attach to the mu opiate receptor, and then they go through a negative feedback loop where they interact with the GABA receptor. But at the end of the day, all opiates shovel more dopamine into the active part of the brain. That is how they give people the high and these spiking dopamines that we see. So I just did two drugs. We could have done other ones, but I talked about two things in the equation that get impacted with addiction. So this is the problem, is that for the 200,000 years that we have been in this human form on this planet, we and our ancestors have gotten used to dopamine levels of an 88 or 150 or on an awesome night 200, and that's what is normal. We have not evolved in the 200,000 years that we've been here. Evolution takes tens of millions of years to happen. So when your brain sees these spikes of dopamine to 350 or 900 or 1300, your brain says, holy smokes, something is wrong here. This isn't okay. I need to turn down the volume. I need to down-regulate. I need to fix this because clearly something's broken in my brain. And the brain's response to these enormous loads of dopamine is to stop making dopamine, turn on every vacuum in sight and suck the dopamine out, and to start to erase dopamine receptors on the other side of the synaptic cleft. So when people struggle with addiction, they have disrupted the reward circuit of their brain in such a specific way that they wake up in the morning and their new dopamine set point isn't 100, right? They wake up in the morning and their new dopamine is a 40 or a 45. They're miserable. And they're not miserable because they have a hangover or they're in physiologic withdrawal. They're miserable at this other level, which is their brain is not having a level of dopamine in it that is consistent with survival. Their brain is not in homeostasis. These are people who never would have made it 200 years ago, and their brain is screaming at them, you know how to fix this problem. You feel terrible. You can improve the situation if you continue the behavior, if you continue to gamble, if you continue to drink, if you go score some heroin on the street corner, you will feel better. So people continue to use. They relapse at times because this is their mode of achieving homeostasis in the brain. What's extraordinary is that people get better. They go into recovery and they actually suffer through and struggle through these periods of extremely low dopamine, which take, by the way, months to improve, and in fact, to get truly better, years to get better. They go through this process. They sometimes go through this process willingly, and they get to the other side. But when your brain is screaming at you to fix something, quite honestly, it's really hard not to listen to it. So this is the concept that I use of the broken brain. I make the story fairly simple because it's the way I've always been able to understand it. It's the way that I help other people understand it. But I want to say to you, who are as a group of experienced people, the brain is a very complicated structure, and many things are involved in the break of the reward circuit. This is a great article that's in the New England Journal of Medicine, and you guys will have all of the slide deck in another 5 days. You can go back and look it up and read it. The article is the neurobiologic advances from the brain disease model of addiction. And I think it is worth staring at the slide for a minute and just thinking it through with me. The blue part of the cycle, of the circle that you're seeing, is activating a couple parts of the reward circuit, the thalamus, the globus pallidus. And this is the part of the cycle where you are actively using, where you're getting high, where you're drinking, when you're inebriated, where you're escaping, when you're running, where you're doing whatever it is you're doing. And that then transitions into the negative and withdrawal cycle of the brain, which is the pink part of the cycle, which is where the basal nucleus and the amygdala and other parts of the brain get activated. And this is part of the brain where you are feeling miserable. You're having physiologic withdrawal symptoms. Your dopamine is in the toilet. You're feeling like a piece of dirt, and you're feeling like the piece of dirt that other people consider you to be. It's not a happy place to be. It's not an easy place to stay. The green part of the cycle is what we call the preoccupation and anticipation or craving part of the brain. And this part of the brain is activated with the hippocampus and with the prefrontal cortex. This part of the brain is the part of the brain that's active when you're incarcerated, right? We may think everybody that's locked up is all good because they haven't smoked in 2 years, so they should be nicotine-free when they leave us. But as everybody who's listening who works in corrections knows, that although nobody smokes while they're in jail, whether it's state or federal or county jail, although every now and then obviously people sneak stuff in general, you're not allowed to smoke in any correctional facility, you would think these people would become not addicted to nicotine. They would be all fixed while incarcerated. We should be releasing everybody off of nicotine knowing they will not relapse on nicotine. But the relapse rate back to nicotine upon release is something like 90%. It may even be higher, because this preoccupation and anticipation part of the brain remains active during incarceration, most of the entire time, but especially at the point when you know you're going to be released. You're 6 weeks before release and you start planning, you start plotting. You're wondering who is picking you up at the curb. Are they going to have $11 in Massachusetts to buy a box of cigarettes? Where are you going to go? What kind of cigarettes are you going to buy? You are thinking about this stuff and you are planning your relapse. This happens with every single drug out there. If we were able to measure the dreams of people prior to release, we would start to see a spike in drug dreams, heroin dreams. How am I going to score my first drug as soon as I leave this building? How will I make it happen? So the cycle that people enter into, the binge intoxication cycle, the withdrawal and negative affective cycle, and the preoccupation and anticipation, is this merry-go-round that people live on when they struggle with addiction. Relapse is unbelievably common because that green part of the brain that interacts with the prefrontal cortex interrupts impulse control. And so people's ability to walk away or say no is influenced. And quite honestly, for those people who are actively engaged in recovery every day, they probably could relapse 29 times a day, but they don't. 29 times a day, they stay sober for yet another day. But I think as everybody out there knows, people do relapse. And when they relapse, they can relapse hard, but they can also relapse dead because the drug heroin or fentanyl these days really kills people at a very fast rate. So I like this slide because I think it really does demonstrate sort of the cycle that we are all on. And just because you're incarcerated and are not exposed to the drug does not mean that a lot of brain change has truly happened enough to get you out of this wheel. So it's worth going back and rereading this article at a later point. So I want to talk to you about what's happened in a local emergency room, because I think you guys represent people from around the state of Florida, so I won't name any single emergency room, but it could be any emergency room in the entire country. This is a guy who lives in Orlando. He's in your top left of your picture, and he's 68 years old and is having crushing substernal chest pain. He wakes up at 5:30 in the morning. He doesn't look so good, and his wife says to him, "You look terrible." And he says, "I must have eaten something bad last night." And she said, "I don't think so. I'm calling 911." And she calls 911, and it happens pretty fast. But in about 6 minutes, I have EMS, and maybe I have fire. I definitely have police. And they're standing in the living room looking at this guy. And they say, "Dude, you look awful. I'm worried you might be having a heart attack." So they give him a chewable aspirin, and they put in some sublingual nitroglycerin under his tongue, and they give him a beta blocker, and they hang in a big bore IV to quiet down some of his pain sensation. They give him some morphine. And this is a cardiac EMS truck, so they're able to transmit an EKG on this guy to the local hospital. And the local hospital ER attendings look at that EKG and say, "Holy smokes, do not stop here. You need to go to a giant university hospital that can manage this guy, because he needs bypass surgery fast." So they race down the highway and they get him to University of Miami. I guess that wouldn't make sense from Orlando. It's too far. There's a big cardiac hospital in Orlando, I'm sure. And they race him into that cardiac care unit, and they have warmed up the cath lab, but he's bypassed the cath lab. And they end up in the operating room, and this guy ends up with quadruple bypass surgery. He goes to the cardiac ICU for another week after that, and then he ends up on the telemetry floor for another week. He has a new social worker because he gets depressed. He has a new cardiologist. He has a new primary care doctor. He has 12 weeks of cardiac rehab because he needs it. And he's all good. He gets better. It's a good story. And usually I ask the participants to guess how much money we just spent on him, but I can't really communicate back and forth with you all. But so I'm going to tell you, depending on where you are in the country, we likely spent between $200,000 and $300,000. So about $250,000 was spent on the 68-year-old guy in Orlando. His next door neighbor on the same street in Orlando is this young 24-year-old woman who's lying on the ground in her bathroom. Her mom wakes up at 5:30 that same morning, and she knocks on the bathroom door but finds that there's no answer behind that bathroom door, and she completely freaks out. I want to tell you a little bit well, let me tell you about her story in a minute. But so she knocks on the bathroom door. There's no response. Kicks the door in, finds that her daughter is blue and not breathing behind that door. She does everything right. She calls 911. She starts basic CPR. And this is a mom who knows that her daughter has struggled, so she administers some Narcan. But her daughter doesn't come back to life. This 24-year-old girl has actually been doing great. She went to a local high school in Orlando. She was a superstar soccer player. She got a full ride to Boston College to play soccer for them. But at the age of 19, she had a massive tear of her anterior cruciate ligament, and she lost her ability to play soccer. She had to have surgery. She actually lost her scholarship to BC. She became very depressed. She'd struggled with some depression and anxiety previously as an adolescent. But she realized she felt better and more normal when she took the opiate painkillers that the orthopedic surgeon gave her. And for 6 weeks, she went back to that surgeon asking for more pain medicine and describing that her knee wasn't healing well. After about 6 weeks, he cut her off and said, "I don't know what's wrong with you, but you can't be coming to see me anymore." And at the age of 19, she began buying pills on the street, found that to be too expensive, began snorting heroin, and then soon moved to injectable heroin, and now a combination of heroin and fentanyl. But 9 months ago, she moved back home with her mom in Orlando and has really worked very hard to get her life back on track. She's avoided all the people that were dragging her under. She got rid of the terrible girlfriend that she was with. She's been going to a local Suboxone clinic and getting really good treatment there. She has a new therapist. She's become a yoga person again. She's out running. She's realizing she doesn't have to be a soccer player to be an athlete. She's building her life back from scratch, and she's feeling great. Her mom, again, has been around the block, and so when that bathroom door didn't respond that morning, she thought there was a relapse happening. So I want to tell you what happened to her when EMS comes with their 2 more vials of Narcan and are able to get this girl back breathing again. They bring her to the emergency room in Orlando, and she's seen by triage and by the nurses and brought in by and evaluated by an attending. But basically, she's released back home in less than an hour. Not much is offered to her. She doesn't get to talk to anybody. And in fact, most people in the ER treat her like a piece of dirt because they think she is a piece of dirt. Two different human beings got very different medical care based on their presentation. But I want to go back to her neighbor, her next door neighbor on this Orlando street, this guy, the 68-year-old guy, because I didn't tell you everything about him. His parents both had significant cardiovascular disease. His mom had a stroke at the age of 62 and died. His dad had a heart attack in his 50s and died. This guy smokes a pack, sometimes a pack and a quarter a day of cigarettes. He kicks back a 12-pack of beer every day, and he would go to McDonald's every day of the week if he could, except his wife tries to hold him back. So he goes at least 4 times a week to McDonald's. And as everybody listening knows, if I ask the question, does this guy struggle with addiction? Your answer would be, yeah, he struggles with addiction to practically every substance out there. He's addicted to nicotine and to alcohol and to salt and to fat and sugar and whatever other chemicals in McDonald's food. This guy is clearly addicted. And if I asked you the question of whether this guy created his heart attack or not, in most audiences, the answer would be, yeah, he created his own heart attack. He caused this problem to happen. Because even though he had some genetic risk with both of his parents smoked. And once we get rid of the tobacco use disorder in this family, the risk for cardiac disease is very normal, in fact. What we know is the number 1 killer in our country is tobacco. And the number 2 killer in our country is lack of exercise and a poor diet. And number 3 is alcohol use. And this guy manages to participate in all 3 of the top killers in our country. EMS, when they arrived in his living room, and the nurses in the ER, and the cardiothoracic surgeon, and the post-op anesthesiologist, nobody made this guy feel like a piece of dirt when he walked into a hospital. Nobody made him feel like he was worthless or subhuman or didn't deserve the medical care he was given. Even though, quite honestly, if they all paused to think about it, they would say, yeah, he made a lot of lifestyle choices that led to this. He wasn't leading a healthy life. And in fact, like many of us who have chronic disease, we participate in the development of our chronic disease. Not 100%, but a lot of it is partly due to our behaviors. And the reason I do the work that I do is I find the disparity in care given to these 2 human beings to be appalling. I don't think anybody should treat these 2 people differently. If we want to treat everybody who struggles with something in their life, that none of us are exercising enough. I ate a bag of toffee before I walked in here that must have had 2,000 calories and was full of fat and sugar, and I felt terrible afterwards, but I'm a sugar addict, and I know it's bad for me, but I have a really hard time staying away from it. So you could shame and blame me for that. You can tell me I can't get a knee replacement because I clearly caused my body's own inflammation, but unlikely that anybody's going to do that. And instead, we treat one of these people with addiction terribly, and we give the other one $250,000 of care. And we either deny everybody care for their chronic disease, which I hope we never get to in this country, or we acknowledge that addiction is a real disease, a chronic disease like every other disease we take care of, and we provide the standard of care that everyone deserves at all settings. What needed to happen to that young woman in the ER wasn't much, you know? Nobody needed to give her a drug. Nobody needed to lecture her. She didn't need an admission for a psych evaluation. This was not an intentional overdose. She isn't suicidal. Somebody needed to sit down with her and say, wow, I talked to your mom and I hear that you've been sober for 9 months. That's awesome. I love that you've been doing so well. She said that you're working now and that you've been going to therapy. Can I just remind you that relapses between the ages of 6 and 12 months are super common? This is when people relapse. They relapse because they're feeling better. They feel normal. They feel good again. And when you feel good again, you think you can test the waters again. You could just dip your toe in one more time. That's normal, right? It's a normal human reaction. And the problem is with heroin or fentanyl or opiates these days, one toe dip in could kill you. So, or one slide back down the alcohol use disorder slide, you could relapse hard and be running and drinking for weeks or months on end. So a relapse is normal. A relapse is normal at this stage. Somebody just needed to sit with her, remind her of that, and said, you know what, in this time period, we need more things coming your way. This is not a time to walk away from a 12-step peer-to-peer recovery. This is not a time to decrease your number of therapy. This is a time that we probably need to up your game. We need to have you exercising more, eating well, drinking a lot of water, going to more therapy. And because your mom also told me you just started working and you just got your paycheck, it could be the case that your mom needs to manage your money for a while. So no money needed to be spent on this young woman, but a good conversation needed to happen. I know I spent a lot of time on that slide, but I actually think this is one of the more important things for us to talk about. Because what happens to people who are incarcerated is just this slide I'm showing you now. The standard of care in our prisons, in our jails, whether they're federal, state, or local, is that people receive the medical care that they would in the outside world. Now, do I do knee replacements? Is everybody getting acupuncture and massage and yoga in my jail? No, not really, because most of my patients in the outside world can't afford that stuff either. But if I have a human being that shows up in my jail with high blood pressure on 3 different high blood pressure medicines, I keep them on their medicine. When somebody shows up with as an insulin diabetic or with emphysema on 4 different inhalers, well, the good news is I made them be a non-smoker overnight, but I continue their medicine for their disease because it is the standard of care, is in keeping with the 8th Amendment of the Constitution, and it is the expectation of the medical care provided to all of our inmates in this country. That is no different than what should be happening to people who struggle with addiction. So for those of you who are still suspect or think I'm a wackadoo, that's all good. I'm fine with that. But I just want to remind you that other diseases break the same way that we do with addiction, that if you look at people who have diabetes, a healthy pancreas is sending insulin to a cell and an insulin receptor that's telling your cells to suck the glucose in. When you have type 1 diabetes, your pancreas doesn't work well and you stop making insulin, so there's no messaging system going to the cells saying, hey, collect up the glucose, there's too much lying out there. When you have type 2 diabetes, you still make insulin, but the insulin receptor gets broken, so it can't receive the messages, and consequently, glucose builds up in the body. Again, I talked about it earlier when we looked at how cocaine and opiates break the dopamine receptors, but it has to do with a messaging system between point A and point B going awry. It looks just like diabetes, but we could do this with cardiovascular disease, we could do this with emphysema, we can do this with any chronic disease in the body where a system of communication between 2 points goes awry. So let's go back to brain. The middle column on this slide is a healthy brain all the way down. And what you see on those coronal sections of a PET scan is that there's a lot of dopamine racing through the brain. The column on the right are brains that are not healthy. These are people who are struggling with substance use disorders. That top brain is somebody with cocaine use disorder. The next brain down is somebody who struggles with crystal methamphetamine. And you can see if you stare at that brain, that is not a good-looking brain. You guys have a big meth problem in Florida. We have a smaller one in Massachusetts. And I don't need to tell you this. Meth is a very difficult addiction to treat. It does not respond to medicine. People have an impact on their brain that takes years to get that better. And some people, to be totally frank with you, will never really recover full brain function because it is such a damaging drug to the brain. And you can see it on that PET scan. The alcohol use disorder is the third one down. I want you to stare at that one. And what you see there is a little shot of orange there. The dopamine system with alcohol takes a long time to shut down. It is the reason why so many of us are functional alcoholics. You work with functional alcoholics, you maybe are functional alcoholics, and you have functional alcoholics in your life, in your family, because this is a common disorder. At least 10% of us, but likely more likely 13% of Americans have an active struggle with alcohol. The wheels come off that bus late in the game. It takes a while before you get your third OUI and you're incarcerated or lost your license. It's a while before your husband walks out on you. And it's a while before your performance at work is so bad that you lose your job. That is when people ask for help. No one, I've been a primary care doctor for 18 years. Not one person has ever walked into my office and said to me, "Hi, I'm an alcoholic and I need you to help me." Instead, I have to drag it out of them kicking and screaming. Or more likely, they get hauled in by somebody else. That's the common presentation of people who are undiagnosed with an alcohol use disorder. Okay, the third brain down is somebody who struggles with an opiate use disorder. And again, you're seeing no active dopamine in that brain. I did get a question saying, are these slides going to be available? And the answer is yes, they're going to be available in 5 days, I think, on the website, and maybe at the break or after the break, because I think we do have a 5-minute break in a little bit. Leanne will remind you how to get them, and anybody who wants these slides can have them. I'm happy to have them shared. I'm happy for everybody listening to this talk to go take this talk and go give it somewhere else. You can take 100% credit for it. I don't care what you do. I mean, don't stand there and give the wrong information. Maybe practice the slide deck a little bit ahead of time. I have some video online that you could watch to practice. So there's 3 things that are going to predispose people or be the setup for who's going to struggle with addiction. Now, many of you are taking care of the adults who already have the diagnosis of addiction, and you can, with your retrospective lens in place, think about this for them. But some of you actually may take care of children, or you may want to be thinking about the children you take care of. Because you know what? People we incarcerate often are parents. And if our country were spending money on prevention like it should, we would be focusing on the children of those incarcerated to help prevent this disease, because this is a preventable disease, truly. So there are 3 things that will set you up for addiction. The first one is genetics. The second one is early exposure while the brain is developing. And the third one is a history of childhood trauma. Having poor mental health does not mean that you will necessarily struggle with addiction. Having poor mental health can be a subcomponent of these other things, though. There's a huge genetic risk for poor mental health. Bipolar, in particular, tends to be very genetic, but so are some of the other mood disorders like anxiety and depression. ADD races through family. We see that one a lot, strong genetics. If you're 14 years old and your anxiety is so severe that you're just having a hard time functioning, you can barely get yourself to school, you certainly can't join the soccer team, you're never going to make it to a party that matters to you because your social anxiety controls your world. But we realize that when you smoke marijuana at the age of 14, you feel better, you're calmer, you're more functional in your own head. You become a person with anxiety, self-medicating with an addictive substance. So it's not that the poor mental health caused the addiction. The addiction with an addictive substance for your poor mental health causes the addiction. And as we all know, poor mental health is a subcomponent of trauma, both directions, meaning living with people who have poor mental health causes trauma, but trauma also leads to significant PTSD and other mood disorders. So let's take these guys one by one. The genetics of addiction are enormous. It is really hard to find another chronic disease with this level of genetics behind it. If you have a parent or a grandparent who struggle with addiction, you have about a 50% chance of struggling with addiction yourself. Now, by the time you're a fully grown adult with an adult brain, knowing this information isn't so helpful because you've already sort of gone down the pathway where you can't make a difference. The reason I talk about this stuff is I really think it's important that kids and adolescents understand their genetic risk for addiction, because they actually get to do something about it. They actually get to change their outcomes if they do something really well, in spite of their genetic predisposition. In fact, you can almost entirely shift the genetics so that the genetics are no longer in play if you make the next decision well. And that is that we know that all addiction is considered a developmental pediatric disease. It starts while the brain is developing. If you can get to the age of 23 or 24 not having used an addictive substance, the likelihood of you developing addiction is about 2%. 2%. That's a single digit, 1 greater than 1%, tiny rates. This is a preventable disease, yet we spend very little time and money truly preventing it. When you ask your people you take care of in a jail setting, in an outpatient setting, at a community health center who struggles with addiction, how old were you when you had your first use? Was it alcohol, nicotine, or marijuana? Those are the 3 most common first use drugs. How old were you? The average age of first use is 12, 13, or 14. When I've asked that question at my little local house of corrections, and I'll have 150 people in front of me, all of whom have been incarcerated for substance use disorder, In that room, I'll ask the question, nicotine, alcohol, or marijuana, who was 12? And every hand in the air is up at 12. And then I start counting down. 11, 10, 9. I have hands in the air at the age of 6. So that's our highest risk population, those who've been incarcerated for crimes, but mostly crimes related to their substance use disorder. And as you would expect, because I have a lot of treatment people listening to this, these are people who had extremely early exposure to drugs that are addictive. If you're 15 years old and you start drinking, and drinking here is defined as 2 alcoholic beverages a week, the age of 15 is your start time, 40% of those kids go on to be alcoholics. If you wait until the age of 21 to start drinking, the rates of alcoholism go down to 7%. So you're hearing and seeing in this picture this giant chasm in terms of age and brain development for your susceptibility or your vulnerability to developing addiction. The reason, again, we tell our kids, the reason, again, we should be having support groups for children of people with addiction or people incarcerated in the perfect world is because those kids, even with genetic susceptibility, can make the choice to avoid addictive substances until their brain is nearly fully developed. And if they can wait until the age of 22, 23, or 24 to have their first addictive substance, the rates of addiction go down to 5%. They started at 50%, and with delayed use, it goes down to 5%. That is extraordinary. That is what shifts genetics. And you know what? Kids are open. When they watch their mom get locked up and leave home for 2 years, and their dad is passed out in a chair every night, you think that 10-year-old isn't open to a different life? That if they could not have the life that they see their parents having, they don't want to change that? I talk to kids every day in my office about how to prevent the disease of addiction. So let's talk about the country, because I think everybody thinks we all spend all of our time talking about treatment and incarceration for opiates and talk about the opiate epidemic. You know, the number one drug of abuse in our country right now, I'm pausing because the numbers are shifting and it depends what state you're in. In some states where marijuana is legal, marijuana has become the number one substance of abuse. I don't care if it's legal, it's still an abused substance. And number 2 is nicotine. But in some states, alcohol is number 1. So it sort of depends what your state you're in, which of those 3 is the number 1 drug of abuse. So in this country, 1/3 of us drink absolutely 0 drinks we never, ever drink. And I used to be like, oh, great, I just saved a couple seconds. I'm going to race through and not ask why they don't drink. But instead, I say, tell me why you don't drink. Because there's a story there. Sometimes they'll say, I'm an alcoholic. And I'll say, I didn't know that you used to struggle with alcohol use disorder. Awesome. How long have you been in recovery? Tell me your story. Or they'll say to me, my dad drank and I hated the smell of it and I hated him for his drinking. He missed all of my Little League games and I never wanted to be him. And so I turned away. And that gives me information about their genetics. It gives me information about their ACE score and what kind of household they grew up in. So I never skip over the question, tell me why you don't drink. 1/3 of us in this country drink very lightly, a drink a week, a drink a month, very light social drinkers. And the final 1/3 of us drink every drop of alcohol in the country. And in fact, the final 10% of us drink on average 10 drinks a day. Now, that seems like a lot, but you guys work with people who have substance use disorder. You work with people who have had their 3rd DUI and have lost their license. You know what people drink. People who drink heavily, a huge amount of alcohol. So what does it take to get to 10 drinks a day? It doesn't take much because we have to remember what is measured as a drink. A single 12-ounce, 5% alcohol beer is 1 drink. Hard liquor, 1.5 ounces, which means for those of you who are bartenders out there, you know what it takes to make a mixed drink. It's often the equivalent of 2 to 3 drinks. You drink a Long Island iced tea, that's equivalent to 5 to 6 drinks because there's so much alcohol in it. So when you're out with your friends and you're having a cocktail, you need to acknowledge what you're drinking. You're not drinking 1 drink with your 1 cocktail. You're likely drinking 2 to 3. There's no shame from me. There's no blame. I just want you to acknowledge the truth about what's going into your body. The real problem these days is the following. Women are drinking more alcohol than we have seen in history. literally in history. The last 15 to 20 years, there's been a massive shift to how much alcohol women are drinking. And we're going to see more women incarcerated for alcohol use disorder than we've ever seen before. I don't think we're seeing that yet, but we're on the early side of this. This is the reason. When I ask my patients, tell me about your relationship to alcohol, that's always the question I ask. Tell me about your relationship to alcohol. Women will say to me, oh, I have a couple drinks a night. And I say, what are you drinking? I drink wine. How much are you pouring? I don't know. A normal size wine glass. And they hold their hand in the air for something that's not a normal size wine glass. It's a giant goblet. It's a mason jar on a stem. Because today's wine glasses are huge. A glass of wine is 5 ounces. And I need everybody out there to acknowledge that and put 5 ounces of water in your giant mason jar on a stem and remind yourself that that is one drink. And that many of us, when we're pouring a glass of wine, are really pouring 2 or 3 or 4 glasses of wine. So I trained at Boston City Hospital in the 1990s. And Boston City Hospital was a hospital founded to take care of poor people in 1865, I think. And really, we took care of poor people, but we took care of alcoholics. And I was a specialist and remain a specialist in alcohol use disorder because that hospital trained me very well. But I can count on one hand the number of women with alcohol use disorder I took care of 20 years ago. Now, I take care of women all the time who really actively struggle. And there's been a huge marketing effort to get women to drink. There's this whole like mommy's time out and all these memes about drinking. It's rare that women won't go out with girlfriends and drink. There's a sense that alcohol is healthy, it's good for you, that it's not going to cause any harm. But what we know is that women are much more susceptible to alcohol use disorder earlier in the game at a younger age. We don't have the same percent water volume, we process alcohol differently, and we get in trouble with alcohol a lot earlier. So this is a conversation for you all to be having with your people that you take care of. I predict for those of you that will be in corrections for the next 10 to 20 years, you're going to see more women struggling. I said this earlier, when I quiz medical students or nursing students about the number 1 or 2 and 3 cause of death, it's always sort of a trick question because they love to say to me, it's heart disease or it's cancer. It depends what state they're from. But I say, well, the real actual causes of death are actually preventable diseases that if public policy and public health had its way could really make a difference. The number 1 cause of death in our country is tobacco use disorder. Number 2, lack of activity and a poor diet. And number 3 is alcohol. Those are the things that then go on to cause heart disease and cancer and strokes. And if we can reduce and change the way that we interact with tobacco, physical activity, the food that goes into our body, we would shift the other diseases. Eventually something will kill us, I get it, but it need not be cancer or heart disease or stroke. This is an article that comes out of Great Britain, and it just talks about the fact that alcohol is a really deadly disease that lots of us struggle with. Statistically speaking, it causes more harm than heroin does. Most of us don't think of it that way, but if you look at this graph, harm to others is the light blue, harm to users is the dark blue, and alcohol exceeds heroin by a big margin. For those of us that grew up in families with people with alcohol use disorder, secondhand alcohol exposure is a real thing. It's not an easy thing to grow up with a parent or a sibling who struggles with alcoholism. Okay, let's talk about the third thing that predisposes you to addiction, and that is having a high trauma score. I'm talking to people who understand trauma, and if you don't know about the Adverse Childhood Experience Study, then the time has come. I think actually everybody listening knows all about this, and you could give me a lecture on trauma, but I want to just talk us through it because this stuff really matters. I think that lots of us think the opiate epidemic was started by the overprescribing of pills for the last 20 years. But some of us would argue that the opiate epidemic origins are really found at high rates of trauma in our country. So the Adverse Childhood Experiences Study came out in 1998. It might have been done in 1996. It was done at UC San Diego out of Kaiser. And it asked 17,000 or so patients as adults what might have happened to them under the age of 18 in their house growing up. It's 10 questions. The questions have a fairly high literacy level, but the answers were yes or no. Scores out of a score of 0 to 10. And I'm going to show you the questions for those of you who don't know them, and I'm going to read a few of them aloud because I need you to be very clear of what we're talking about here. because people who are incarcerated have unbelievably high ACE scores. That's a surprise to nobody, but nobody pays attention to this one, okay? Did a parent or another adult in the household often or very often swear at you, insult you, put you down, or humiliate you? Did a parent or another adult in your household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Were you ever sexually abused? Did you often or very often feel that no one in your family loved you, thought you were important or special, or that your family didn't look out for each other, feel close to each other, or support each other? Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you, or that your parents were too drunk or too high to take care of you or take you to the doctor when you needed it? Did you watch your mom or your stepmom be physically abused by your dad or your stepdad? Was there somebody in your household with major mental illness? Were your parents separated or divorced? Did you live with somebody who was a problem drinker or used other substances? Was there somebody in your household who was incarcerated? 10 questions, yes or no. If you score a 6 or higher on the ACE score, you've likely just shaved 20 years off your life. If you score a 3 or higher on an ACE score, you're at higher risk for heart attacks, asthma, COPD, chronic pain, much higher risk for addiction, multiple broken bones. It is a predictor, actually, for every chronic disease out there, with the exception of strokes and I think diabetes. Those two aren't showing correlation. But otherwise, this is a measure for those of us that are going to struggle. And quite honestly, I should be using this, and I do use this, like a vital sign in my office, because it is a predictor of who is going to have trouble. Having a high ACE score means that you're much more likely to get incarcerated. And if we want people to leave our jails and not return, which is always my goal, and the truth is it should be the goal of everybody else out there, you need to actually get at treating their trauma. And if we're not treating people with a history of trauma for their trauma, we're not actually helping them. And you guys, again, know a lot about trauma. I'll show you a book at the end that I think is good, and we'll talk a little bit more about it. So let's dive in for a minute on opiates. I said it earlier, but there's no doubt in my mind and most people's mind that the overprescribing of opiates since 1996 is on the hook for this opiate epidemic. It certainly began it all. It's not where we are in most parts of the country right now. Florida has actually a very low rate of opiate prescribing. You're going to watch me just crash Florida for about a few minutes in a second because I have to walk you through what happened in the early aughts. When you look at the nation, the red areas on these maps are places where overdoses are happening at very, very high rates. And you see in 2003 that the country wasn't so bad. You see that parts of Florida light up and the central part of Appalachia lights up. But you watch us march through the entire nation, and we end up in 2014 where you see overdoses happening everywhere. And 2014 is before fentanyl has really hit us. We don't see fentanyl really spiking in New England until about 2016. And at this point, with the exception of North Dakota, most of the country is deep maroon. Like that map doesn't exist, but it's out there as a visual, and it is a real problem nationwide. I trained in New England, as I just said. We used to call I-95 Oxy Highway because we were getting our pills from your fine state starting in the late 1990s until about 2009 and 2010. And as you guys know, because you were maybe living down there then, there were 650 or 640 pain clinics spread around Florida. You could walk into a strip mall and find a couple of these. And we used to send tour buses down to Florida to do a little bit of pill shopping and script shopping. And people would have their way paid for and meals paid for. And they could walk into any of these pill mills and get whatever they needed without even a real diagnosis. They didn't need to be old. They didn't need to limp. They just needed cash. And those pills would go back to Maine and Western Massachusetts and Kentucky and be sold on the streets. And it was a massive problem. And the federal government looked at your fine state and said, holy smokes, what are you doing? You're sending these pills everywhere, and many, many people are getting addicted. So stop it. And the federal government and the DEA in 2009 and 2010 shut down most of the pill mills and pain clinics in Florida. And Florida has actually become a state where it's hard, if you have chronic pain, to get opiates to manage your treatment. I'm not saying that pendulum swinging that far is necessarily a good thing. I actually have patients I take care of in Massachusetts who sometimes go to Florida. And these are not people struggling with addiction, but they can't get their severe spinal stenosis treated by a local doctor down there. But having said that, the shutdown of these pill mills, the ending of this sort of like doctors handing people pills and scripts for cash. 34 doctors went to federal prison because they were really drug dealers. They were not really practicing normal medicine. And when you have shut down the entire pipeline of opiates that headed up I-95, and you have 2 million or 2.5 million Americans addicted to opiates, you've shut down the pipeline, what are you left with? And I can't hear a darn thing out there, but my guess is that some of you said the answer is heroin, that we had a wide distribution of heroin that began to get distributed in small towns and haulers throughout the country starting in 2009. So there was a ready supply of an available drug to replace the missing pills. It is cheap, it is pure, and it kills. And we weren't prepared for that. We were not prepared for the death rate that descended upon us. So when you look at the country, going far back as 1968 until 2015, people die less likely from car accidents than they used to, and that's extraordinary. And if I asked you, why is that? Why is the death rate from motor vehicle accidents going down? You would answer, seatbelts, safer cars. It's awesome. I think now that texting is on the up, I think we're going to see this number go up, but for now, it's gone down. That's good. When you look at how many people in the country have died from gun violence since 1968, it has gone up, but it's actually been pretty flat. In spite of the terrible, horrific public murders that have still happened all the time, overall death from guns has been flat in this country. When you look at dying from AIDS, there was no AIDS, and then in the 80s, it came upon us. And the peak of the AIDS epidemic was in the early 1990s, and then successful available treatment happened, and the number of people who die from AIDS has continued to diminish. When you look at all of those things, car accidents, guns, and AIDS, and compare them to dying from overdose, as you can see on this map, overdose has now exceeded them all. And this chart, it goes up to 52,000. Last year's number from the federal government were 72,000 people dying of death by overdose. When you ask EMS nationwide, what's your number one drug of concern, those dark areas, the answer is heroin. Then when you look at other maps of the country and you are looking at what states still have high rates of prescribing opiates, those dark purple states still have a very high rate of prescribed opiates by doctors or other clinicians in the community. And so the thing is, while you still have highly available prescribed opiates, heroin doesn't have to take over. And so when you look at the country with heroin or fentanyl, those red and orange areas, very high heroin and fentanyl. I'm going to go back to that purple map that shows high pill rates. But what we know is that as of January 1st of 2019, 2 weeks from now, Medicare, the insurance that takes care of old people, will no longer cover prescribed opiates over a certain milligram equivalent of morphine. It's going to be cut off at the pharmacy, done. This is going to be a shift that is going to alter the way people access their prescribed opiates. Now, most people prescribed opiates are not addicted to their opiates. They use them for chronic pain management. Most of them use them well, and some of them get relief from it. And so it's going to be a massive pendulum swing when this happens. And those purple states we're seeing, when there's a percent of those people who actually use opiates and abuse them, will convert from prescribed opiates to heroin, and we will see the death rates increase. Leanne, this might be a good place for a 5-minute break if people want a break, but I'm also happy to keep going. I want to have time to do everything.
Take a break. Thank you, Dr. Potee. I've got 3:03 on my computer clock. So let's reconvene at 3:08. Thank you. Welcome back, everyone. Dr. Potee, we did have one question that came in related to one of your early slides related to the brain cycle. Would you like to address that now or perhaps loop back to that toward the end of the presentation?
Leanne, I so apologize. Will you repeat that question one more time?
Yes, I was just going to ask you, a question came in related to the early slide that you showed related to the brain cycle. And so we've got a question related to that. Would you like to address it now or loop back to it at the end?
Let me do it at the end, only because I'm a little anxious. I've got to get through. I thought I'd have a gazillion minutes, but now I feel like I've got to move a little faster. So let me go back to it afterwards.
Of course, thank you. And whenever you're ready, you can proceed.
Okay. Okay, everyone. So let's talk about incarceration rates and about treatment in jail, because that, I think, is why everybody signed on to this talk. And so you may think, boy, she took a long time to get there, but we all needed to be at the same foundation. So I think everybody knows this, but we incarcerate more people in the United States than anybody else in the entire world by a huge margin. So when you look at us and break us down, not just as a nation of 50 states, but you look at us state by state, Oklahoma is the #1 incarcerator in the entire world. And then the numbers go down from there. Florida is in the top, very bitter end, I think, of the top 10 or 12 in the world incarcerating people. And then the next country after us is El Salvador and then Turkmenistan. So I don't think we're keeping good company here. So this country does what no other country does, and we lock up our citizens at high rates. When you look at us compared to 1980, so this is 2014 data versus 1980 data, the number of people in state prisons, you can see the gray number, the gray bar versus the green bar. Federal prisons, look how few people we had in federal prison in 1980, 4,700 people. And then in jails, how much higher that number has gone. So again, huge numbers of incarcerations, and this is for drugs as the first offense. Florida, again, incarcerates a lot, not as bad as Oklahoma, but you guys are right up there, and certainly more than any other nation in the world. So I think for those of you who actually work in the jails, I don't know what % of your inmates are there for substance-related problems. At my little local jail where I'm the medical director, we think the rates of substance use disorder are between 85 and 92%, very high. And that's true, I think, across the board, that very high rates of both alcohol and other drug use is part of people's reason for being incarcerated. Sometimes it's the only reason they're incarcerated. You know this, but leaving jail is the most dangerous time for someone to die of an overdose. And it has 120 times the rate of overdose that normal people have. This is an incredibly high risk time. That first 30 days is critical. That is when most of the overdoses happen. Not even the first 7 days, but some of the data you'll look at will say between 7 and day 28 are some of the highest risk times. So we spend a lot of money. In Massachusetts, it's like $52,000 a year on our inmates. And we spend a lot of money to keep them well and safe and fed and clothed so that we can release them for them to die. It doesn't make a lot of sense. We know that people actually get better with their disease of addiction. It is absolutely possible to get better with addiction. I would argue it's actually the norm. I think that for some of us who are in the business, we see people who are chronic relapsers and we forget how many people get better, how many people amongst us are in recovery and look like this young woman on the right. They're looking all good. Who knew? But people get better. But they get better because a lot of things are working in their favor. And this is what makes it get better with addiction. 1,000 different things. It isn't one thing. The #1 thing that you need to get better with addiction is housing. If you do not have stable, sober housing, you will not make it. And the biggest problem we have in Massachusetts, but this is a problem nationwide, is that we send people from our jail right back home to the same house, same neighborhood, with the same girlfriend who's still actively using, and that person will not make it. They will not be able to live a life of recovery, a life of being crime-free if we send them back home. But I imagine that anybody who's doing reentry work or does that kind of work out there will acknowledge there's no place for my people to go. So when I sit down with a patient who struggles, I make a giant circle and I put in some pie pieces and I say on everybody's pie is housing. And then the other stuff shifts depending on who you are. It takes a lot to get better, though. That I believe in medicine to help people with addiction. I believe in great mental health treatment. I believe in trauma treatment. People need to have a sense of purpose. They need to work. They need to give back to society. They need to be able to go to school. They need to be able to vote. So I'm glad Florida made a change on that one. People need to be able to restore relationships with people they've screwed up with, family members, kids, friends. They need to be able to connect to other people to rebuild the dopamine system in the brain. It's good to fall in love, whether it's with an animal, a horse, a child. It is good to reestablish a positive, loving relationship. There's no one who feels worse about themselves than the addict, and having a developed positive self-esteem is one of the hardest things to come by, but to get better, you need that too. So people's pies are really complicated when it comes to getting better. I believe in the medicines for treatment for opiate use disorder. They're well supported, well evidenced. You guys all know there's 3 out there at the moment. There aren't any coming in the pipeline that I'm aware of. They're just different forms of this. But methadone we've had since the 1970s in the U.S. Buprenorphine, also called Suboxone. I will call it buprenorphine during this talk. And naltrexone, known as the shot form Vivitrol. I will call it naltrexone. It comes in a pill form during this talk. So 3 treatments for an opiate use disorder that have very good evidence behind them. None of them are new. I want to talk about methadone because methadone is one of the most important, most well-researched, long-standing, unbelievably cheap drugs out there, and it is so heavily stigmatized. This is this glorious study. It's my favorite slides in this whole slide deck of a study that happened in Sweden in 1980 or in 82. I can't read when it was. It was 80, I think. And in this study, they took 34 people struggling with heroin. Those are the red H's. 34 people struggling with heroin. Is that my math right? I think so, yeah. They took half of them and said, look, we're going to get you into a methadone clinic. And the rest of you, you need to figure it out. Just make yourselves better. 17 of you go to methadone. 17 of you get better on your own. Go to meetings, make it work. And they followed them for 2 years. And after 2 years, the people in the methadone clinic, a lot of them were good. The green people are fine. Some of them are still going to methadone clinic. Some of them are weaned off methadone, but they're doing well. They're not using heroin. They're not getting spinal abscesses. They're working. They're taking care of their kids. One person in the methadone group is a P. They went to jail. 4 more people in that group are still using heroin. In the group that we looked at, those 17, and said, hey, figure it out, make it work, pull yourselves up by the bootstraps, 1 did good. All good, in the green, feeling well. 2 went to jail. A whole bunch are still using heroin, and 2 are dead. Of those groups still using heroin, 1 got sepsis and endocarditis. 1 had their leg amputated, and 1 had sepsis. So that's at least $250,000 on those 3 people, a lot of money. So they went back and they said to those people who had not doing well, look, the people on methadone are doing well. You guys are all a hot mess. Let's invite anybody who wants to go into the methadone group to come into the methadone group. So 5 years later, they follow them all. So all those green people are good. They're either going to methadone clinic or they're not using heroin, but they're doing fine. A whole bunch of people are doing fine. In the original methadone group, that person in jail is still in jail, the long bid. 3 are still using heroin. 1 who was using heroin got better. When you look at the no methadone group, a whole bunch of them are doing well. The original no methadone group, but they're in methadone now. The green ones are doing well. 3 of them are now in jail. 5 of them are now dead. Methadone is an unbelievably effective, cheap tool. The problem is it's not highly available because it's unbelievably heavily regulated in this nation, and there's not been a single change on the regulations of methadone since there.
Dr. Potee, are you okay?
Relapses are high. When they use treatment, it's less high. When
Dr. Potee, can you hear me?
I can.
We lost your audio entirely, maybe at the beginning of this slide, if you might want to repeat yourself there.
This slide here that's entitled What Actually Works.
Yes.
Okay, can you hear me now?
Yes, it's a little scratchy, but I can hear you now.
Okay. So this is a 3-year, 36-month span of time that looks at relapse rates. Leanne, how's my sound? Better?
Yes, better, thank you.
Okay. So if over 3 years' time, the green line is people who are going to meetings, maybe going to therapy, or figuring out how to get better on their own. And what you see is the relapse rate there is high. It continues to progress along over a span of 36 months. The blue line is buprenorphine, the red line is methadone, and the relapse rate is much lower. This is the cost of those treatments. The cost of buprenorphine and the cost of methadone are less than the cost of doing nothing but going to meetings, going to therapy, and figuring it out. Because when you're not using medicine, the relapse rate is high, and relapse is expensive. Relapse causes endocarditis and spinal abscesses and sepsis and ER visits and death and lots of other things. It costs a lot of money to relapse. So it still costs less money to treat people than to not. So what is the best treatment for people? Whichever one works is the right answer. Whatever one is going to help this person stay stable is the right drug for them to be on. How do you know what the right drug is for them? You ask them, has there ever been a time where you've done well? Tell me about a time where you had things going your way. You weren't actively using a substance and your life was back on track. And people will give you many answers. They will say, I moved to the middle of nowhere, northern Vermont, and I was all good. And then I say, okay, how can I get you back to the middle of nowhere, Vermont? Because that seems like a good place for you. Or they'll say, I took buprenorphine, I was in a clinic, I was doing well for 18 months, I had a job, I had a car, everything was great, and I lost my insurance, and it all went to hell. So that's somebody for whom getting back on buprenorphine and getting them back on insurance would really help them. So I listen to people and hear where they've been and how long they've been using and what might be the right drug for them, knowing that I don't always get it right. When you look at naltrexone, also again called Vivitrol, this is the more common drug available in our houses of correction nationwide, partly because the company that makes this, Alkermes, gives it for free. It doesn't mean it's a better drug. It's certainly a less judged drug by others, but does it work really well? First of all, we give it upon release. And in my own experience in Massachusetts, our rate of follow-up for repeat naltrexone shots was quite low. Fewer than 20% of people who left my house of corrections bothered to get their first or second shot. That's not a good predictor for me. That's not somebody who's doing well with long-term recovery necessarily. And so the relapse rate tends to be high. A study came out in January of this year that was the first direct comparison between buprenorphine and naltrexone. And what it found is that they were about equal in terms of efficacy in decreasing relapse rate, which seems great and exciting. And the concern, though, is to actually get to naltrexone takes a lot of work. You need probably 10 days free of an opiate to get onto naltrexone, which means coming from the streets, it's a very hard thing to grin and bear it for 10 days with no opiate to get to naltrexone. So in this study, it was a little bit like comparing apples to oranges. There was a group that was able to push their way through for those 10 days and make it happen that they could get their shot, and there was a large group that couldn't successfully get there. They fell out of the group and went back to Suboxone. So there is this apples to orange comparison. Are we even talking about the same kinds of people? Again, we see less efficacy with naltrexone, but I keep it always in my arsenal for people who want it. There are many ways to use these medicines. The most common is orally. Methadone comes in a pill and a liquid. Buprenorphine comes in a pill, a little sticker that goes on the inside of the cheek, a dissolvable pill, a little strip that dissolves under the tongue. All buprenorphine products, if they go orally, are not swallowed. They're absorbed through the buccal or the sublingual mucosa. That's the way that drug is absorbed. It is not a swallowed drug. Its absorption when you swallow it is almost zero. It's very poor. There's a form of buprenorphine that comes as a little rod that goes in your arm. There's a form that came out in February that's a shot form that lasts for 30 days. So as of the end of November, 2018, 3.5 weeks ago now, or 3 weeks ago now, a decision was made in a federal court in Massachusetts that said to a local county jail, you must maintain an inmate on methadone. If you do not maintain them on methadone, you are in violation with the Americans with Disabilities Act and the Constitution. This is a game-changing decision, and you may not think it's affecting you yet, but I am telling you this decision will affect you. This says that when people are stable on their treatment, whether it's buprenorphine or naltrexone, or they're using naltrexone for an alcohol use disorder, or they're using methadone for an opiate use disorder, you cannot stop their drug. You need to maintain them on it. So this was a case where a guy who had been stopped for some sort of moving violation. Maybe it was an OUI, but it was some sort of vehicular violation. It took forever for that case to go to court. And he, at the time that he had been charged, wasn't doing so well. But then he got stable, got away from opiates, went to methadone clinic, and had been stable in a methadone clinic at a stable dose for 2 years. He was all good. He's doing great. He's working. He's supporting his family. The thing finally worked its way through court, and he's facing a 90-day sentence. And what he said is, I need to get my methadone in jail. And the jail said, we don't do methadone here, and he took them to court. And the ACLU fought for him. It was a beautifully written decision. It's on my website. If anybody wants to read it, it's on the website that I'll show you at the end. You can go read the court decision. But this jail has got to figure out a way to get this guy his methadone. You figure it out, or else he's not going to go to jail. So this decision has come down. Again, it just happened 3 weeks ago, and we're going to talk about how to make this happen in your facility. I think I showed you guys this slide here. Oh, I just want to show you a change that we're seeing. That this slide here is 2015. Those green areas are high problems of heroin. These red areas right now are high problems of heroin. It's really spreading. The heroin problem is now everywhere. This is a map of the nation, county by county, that looks at the prescribing of opiate prescriptions written by a clinician, an NP or a doctor or a PA. And what you see is that there's very high rates of opiate prescribed in many counties in this country, many of which are not too far away from you. And with this change in Medicare guidelines, we're going to see these places turn to some more heroin use. The overlay between economically distressed communities, this is a map of economically distressed communities here, is very high with high opiate prescribing. If you look at those two maps, you can see it's not 100% overlay, but there's a big consistency in that. I think I showed you this one already. And these are books about addiction that I think are really good if you haven't read them, or if you think to yourself, wow, I need to know more. I need to be able to go back to the jail and run a group and talk more about this. Every one of these books is great, I think. The Body Keeps the Score is the best book on trauma I've ever read. It's the one I always turn to. That's that top one with the dancing black figure. And this is a book that talks about what trauma does to the brain, what trauma does intergenerationally, and how to help treat trauma. And it's not at all focused on corrections, but you could take lessons from it. So my website is this. It's just my name, ruthpotee.com. And on it are some video that you can watch and practice before you give this talk. But also I put up articles there that talk about things. So we have been doing at my jail here in Franklin County in Massachusetts, we have been keeping people on their buprenorphine if they were already on it for 3 years. And as of the beginning of this year, 2018, if somebody came in not on buprenorphine and clearly had an opiate use disorder, either by history, overdose recently, a urine with heroin or fentanyl or another opiate in it, we then said to them, would you like to get stable on buprenorphine while you are with us? And if their answer was yes, then we stabilized them on buprenorphine. There's another route through it, which is that we could look at people prior to release and say, look, I know you've been here for 10 months. I know you've been all good. I know you think you have this, but statistically speaking, you don't have this. The likelihood of you relapsing when you leave us is really high. And if you're starting to have drug dreams, if you're starting to think about using, we need to acknowledge your risk now. let's start you on a very low dose of buprenorphine before you leave us and get you a clinic appointment when you leave us so that you can go straight to the clinic and be safely maintained on your buprenorphine. Our goal is to get everybody who needs to be on methadone on that drug too. It is a complicated process, and the way it's worked in other places, Rhode Island does this everywhere, is they contract with a local methadone clinic who brings the methadone in. So they use their local methadone clinic license, and their local methadone clinic uses the jail as a satellite clinic, which is allowed by law and the federal regulations. If you're a methadone clinic, an OTP, you can create a satellite clinic somewhere else. It could be a hospital, it could be a jail. And for them, it's all money. What do they care? They're delighted to have more clients. And they don't have to do the treatment at most of the facilities, although some of them do choose to take on the treatment. If the jail's doing the treatment, they don't have to do that part. So in my case, at our local jail, our goal is to actually become our own methadone clinic. I don't have a high-functioning local methadone clinic currently, so I can't rely on them to bring methadone into my facility. So we are jumping through all the hoops it takes to become our own methadone clinic at our jail. The drug itself is going to cost 10 cents a day from the state pharmacy, but jumping through the federal hoops to become an OTP is pretty challenging. Partly because the federal government hasn't done this before and they're very confused. And I keep saying, but I'm a jail. I don't need that. I don't need this or that or that. And they keep asking about our security situation, and I keep reminding them I'm a jail and I have unbelievable security. So once we get 1 or 2 or 5 of us having done it, the federal government and the state government will have figured it out, and it will become an easier process than it is right now. So I think this is a great time to start taking questions that people have.
Thank you, Dr. Potee. And it looks like one we have does go back to that brain cycle slide. And it asks the question, how do people in long-term recovery repair this cycle?
Yeah. So it all has to do with time. What makes everybody better is time. But time is not real time when you're in jail. Because what we're talking about is restoring the dopamine system in the brain. And what restores the dopamine system in the brain is engaging in the world and having a job, having a sense of purpose, restoring relationships, getting tons of exercise, feeding your body well, doing everything it takes to get better. And as I think most people know who are listening, who work in the field of incarcerated humans, most jails aren't such happy, pleasant places where dopamine gets restored easily. And in fact, in many of our houses of correction, people get harmed, right? Worse things happen to people in jail. Your dopamine system gets even worse, even more disrupted. So it has to do with being in the real world, engaging in the world in a healthy way, having time and distance away from the substance, and rebuilding the dopamine in the brain so that it becomes more like my brain and your brains and more normal, which is very doable. That's how you get out of that cycle. It is really hard to have that cycle end while you're incarcerated.
Thank you. And I've got another question here. And then there's also a question that I'm going to have you read, Dr. Potee, yourself, just because it's lengthy, but we don't have to do that one right yet. But so here's my second question for you. Do you have any tips for working with local sheriffs on MAT in jails, especially if the sheriff does not want MAT?
Yeah, so my local sheriff didn't understand anything about addiction or the brain or any of this as of 5 years ago, and now he could go give this talk. He probably does go give this talk all over the place. He had to change his mind. He had to learn more information. And I actually think that when you take this talk and you go deliver it to the local sheriff association, you can change their minds. I really believe that because we see it happening. We have shifted the way people think out there a lot by telling them how we understand the science. So, but it's a grassroots effort. The sheriff and I know each other well. I work for him. And the way it unfolded at my jail is one of my patients that I take care of who has a substance use disorder was totally stable on his buprenorphine, was stable on his buprenorphine for years. He ran his own landscaping company. He got picked up for a DUI because he drinks too much, and he got incarcerated. And I saw him when I was at the jail, and I said, "How are you?" And he said, "I'm terrible. I'm terrible. I'm withdrawing from opiates. All I want to do is use heroin. It's all I can think about." He had become just like a hand grenade waiting to explode. This is a guy who was super stable and fine and had his life on track and then drank too much and got himself in trouble. So I went home that night and I sent a note to the sheriff and I said, "Let me tell you the story of one human being who we took off his medicine." And by the next day, the sheriff said, "We shouldn't be taking people off their medicine that keeps them stable. Why are we doing this?" So sometimes people are really open to the change. Some people need to be shifted more. I tell you, if your sheriff is going to face a lawsuit because of this, they may want to change their minds because they don't want the expense of a lawsuit. This federal decision is a big decision. Leanne, should I read aloud the question that was asked?
Yes, I think that would be fine. And you see it's in the chat panel, so just read it however you like and then however you'd like to address it.
Okay. It says, how do we work with inmates or clients who are now terrified of MAT? They're scared of using either buprenorphine or Vivitrol or methadone. And then they also go on to say in this question, we also have inmates who say they're addicted to methadone. And why would we give it to them while they're incarcerated and then have this addicted population? So let me separate those two questions out. This is what I'll say is I take care of people I run an alcohol and drug treatment center, and people come in and they say, "I just want off everything. I want to be off this." And I say, "I want you off everything too. And if I had a magic wand, I would strike you in the head and you would have your life back on track and things would be great." But it doesn't work that way. That's not realistic. When I look at my patients who are massively obese and have high blood pressure and diabetes, I say to them, look, you could get better from these things. It's going to take a massive amount of change in your life. You're going to need to lose 80 pounds and start exercising and change your diet and empty out your pantry and learn to cook better, et cetera, et cetera. It's doable, but it's hard. And in the meantime, I'm going to give you some medicine for your high blood pressure and some metformin for your diabetes while we keep working with you on these other changes. So the conversation I have goes like that. I want you to be off everything too, but it's not likely to happen that you are going to get stone cold sober in one try and be all good. And instead, you're so unwell that this is your fourth time in a treatment center. This is your second time with incarceration. This is the fourth time you violated probation. You're not doing well. By anybody's measure, you're failing. And so if everything we've tried hasn't worked, can we be open-minded about trying something else? I do not get paid by the drug companies. I am an anti-drug person in general. If you come to my office, I'll spend my time trying to get you off of medicine. But I have a drug that is a serial killer on the street called fentanyl and heroin right now, and it is dropping young, healthy people every single day. They are dying, and I have effective treatment that's going to prevent that. I'm on board for that. So yeah, sometimes it takes a firm conversation, but when I have people say, I don't want it, I say, that's fine. I understand you don't want it. You don't have to have it. My job is not to force people onto things. Just know that it works better than doing nothing, but if you're not interested, that's fine. And if you decide later, 9 months after you've done your time in jail, that you're reconsidering and maybe you should be on it, we can start it then. So the question about inmates who are reportedly addicted to methadone, I'm going to parse that one a tiny bit. So if you're saying they're addicted to methadone, it means they're buying methadone on the street and using it to get high. So they've developed an unhealthy relationship to an effective drug. We could have substituted the word methadone out for buprenorphine, meaning that there's a lot of people out there who abuse buprenorphine. Most people don't get high with buprenorphine because it has a ceiling effect, but they sell half of it. They use heroin intermittently with their buprenorphine. Some people actually inject buprenorphine, which seems crazy because they get Narcan first before they get a little buzz out of it, which seems insane, but yet people do it. What I say is, look, maybe the buprenorphine is not a good drug for you because you've developed such an unhealthy relationship to it. Maybe we need to think of a different treatment. People buying methadone on the street, it's possible. It's hard to get methadone, but it's possible. And if they've developed such an unhealthy relationship with methadone that they're abusing it, misusing it, using it to get high, then we would be offering them something different than that if they wanted it, which is a stable single dose once a day of a reasonable amount of methadone that is not going to make them nod off or get high. So I think that it's really important for people to understand there's a big difference between being addicted to an opiate and then using an opiate agonist that doesn't get you high, that is not misused, that is carefully monitored to help keep your brain stable so you can work on getting better. And then over time, when people's lives get better, we wean them off of these drugs. Some people will never be off their methadone or off their buprenorphine. That's fine with me too. Some of my diabetics will never ever be off their metformin. I don't judge it. I let it go. But if people are doing well and they want to start working off these drugs, I'm 100% supportive of that.
Dr. Potee, thank you. And that's all the questions that we have right now. And if you're ready, we can go ahead and conclude the webinar. If you have any other remarks for the group.
I didn't have a summary per se. Again, this slide deck is available to you. If you go to my website, there's video that's associated. You could use this slide deck if you're doing group treatment for anybody. If you thought it was helpful, I would love for you to use it. Again, don't credit me, do whatever you want with it. But I think the more we're able to use and educate both people who struggle with a substance use disorder, but also their families, society in general, we have a long way to go in this country to help change people's minds. We're going to be at this for a while. And Rhode Island is really the people that we're following. The Rhode Island House of Corrections has been using both methadone, buprenorphine, and naltrexone in their House of Corrections since the beginning, I think, of about 2017. And their data is very good, extremely effective. The rates of contraband in the jail have really diminished, and the rates of relapse after release are much, much lower. So thank you for being here with me, and happy holidays to everyone.
Dr. Potee, thank you very much. We appreciate you being with us today and taking time to share your expertise. It's been a very interesting presentation. And if you're ready, I'm going to take control back of the presentation and bring us in for a landing. So everyone, as we wrap up today, I want to remind you that when I conclude the webinar, your browser is going to take you to an evaluation on FADA's website. If you want to receive continuing education credits or statement of credit, please do complete the evaluation for us. You will be prompted to register or sign in to complete the evaluation, and you can certainly register as a visitor at no cost. For your continuing education to be reported to CE Broker for certain Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register with us. And then after you register or sign in, you'll be directed onward to the evaluation. You'll also get a second opportunity to complete the evaluation if it's not convenient for you now. You're going to be receiving a follow-up email later today in about 30 minutes. And the sender will be FADA On Demand, Messenger at WebEx. And remember, the evaluation closes tomorrow at midnight. And then finally, let me just say to all of you, thank you for participating in today's webinar. And of course, would also like to recognize and thank especially the Office of the State Courts Administrator for funding today's education. So have a great rest of your day, wonderful holidays, and please hold now for the evaluation. Thank you.